So thank you everyone for joining this national education session on the management of pregnancy and sickle cell disease that is being very kindly given by Dr. Mamta Sohal. Thanks again for everyone for attending, and I'll pass you over to Asad.
Okay, thank you, Ralph. So I'd like to thank Dr. Mamta Sohal for giving this talk to us today on management of sickle cell disease during pregnancy. So just to give you a little short biography about Mamta. So she completed her haematology training in North West London and then initially worked as a consultant haematologist in Hillingdon Hospital. She moved to her current position in Hammersmith Hospital in 2019, and throughout her career has developed a special interest in hemoglobinopathies. And she's got a number of roles in her current position. She runs a joint obstetric hemoglobinopathy clinic together with the obstetricians at Queen Charlotte's and Chelsea Hospital, and is also involved in the West London HCC, where she's the lead for training and education and for developing the HCC guidelines. I should also mention that she's also the local PI at our centre for the TAPS2 trial. And if that all isn't enough, she's also the training programme director for North West London for the haematology rotation and manages over 50 haematology trainees. So Mamta, I'd like to hand over to you to start your talk.
Thanks, Asad. I've actually just had my appraisal, so a very reflective mood, but I would say that I really enjoy the joint clinics that I do. So I do this obstetric haematology clinic, as Asad said, with Miss Jasmine Tay at Queen Charlotte's, and I also do a paediatric haematology clinic at Hillingdon. And I love the joint clinics. I feel I learn a lot about, especially so I've learned a lot of obstetrics and I've learned a lot of paediatrics in doing these joint clinics. And hopefully I've taught my colleagues a bit of haematology as well. Oh, let's see if it does. So the topics for the discussion today are take you right through from preconception care to postpartum care. And we'll also talk a bit around the role of transfusion in pregnancy, contraceptive advice for women with sickle cell disease. And I wanted to end with a case presentation, which I think really highlights the importance of multidisciplinary care in specialist centres for women with sickle cell disease who are pregnant. So there are about 100 to 200 pregnancies annually sickle cell disease out of approximately 12 to 15,000 individuals living with sickle cell in the UK. The maternal mortality rate is now thought to be less than 1%. The Embrace UK, which is a mother and babies reducing a risk through audits and confidential inquiries across the UK, produced a report in December 2020 looking at maternal deaths and morbidity between 2016 and 2018. And there were 4 deaths reported within that triennium, which was compared to 1 in the previous triennium. And the example that they give in the report is this scenario, is this situation. A woman with sickle cell disease developed chest syndrome in her first pregnancy and had a delayed transfusion reaction. This made her reluctant to accept blood transfusions. In her second pregnancy, she agreed to a transfusion in the 3rd trimester. A few days later, she attended the emergency department with abdominal and limb pain, chest signs, and was hypoxic and tachycardic, having developed hyperhemolysis syndrome. It took several hours for the medical team to review her, and she spent 10 hours in the emergency department, during which time she was not given oxygen or intravenous fluids. Neither the obstetric nor the haematology teams were asked to review her. She was then transferred to the labour ward, and it was a further 7 hours before she was transferred to ICU as a bed was not available. A fetal bradycardia occurred, leading to an emergency caesarean section. She had a complicated post-operative course, culminating in cardiac arrest and her death. So their recommendations from this was that women admitted with sickle cell crisis should be looked after by a multidisciplinary team involving obstetricians, midwives, haematologists, and anaesthetists. And obviously there's the green top guidelines that were published in 2011. The critical care support, it was emphasised, can be initiated in a variety of settings. Critical care outreach work, nurses can work in partnership with midwives to provide care before transfer to the critical care unit. Delay caused by pressure in critical care is not a reason to postpone critical care. Outreach or equivalent service should be available to ill women and provide support and education to health professionals delivering enhanced maternal care. They developed some standards around care for the critically ill woman in childbirth. So very sobering. In the report from 2021, which was even more sobering, I think actually made national headlines, was how maternal mortality is affected by your ethnicity, and how women who are Black have significantly higher mortality rates in pregnancies compared to white women. And then equally, those of socioeconomic deprivation, those who have the highest amount of deprivation were had a much higher associated mortality. So with sickle cell disease, obviously sickle cell disease itself increases your risk in pregnancy, just by the fact of your ethnicity, increases your risk of dying in pregnancy. And for some from the lower socioeconomic groups, where there's higher socioeconomic deprivation, the risk is increased even further. When we're looking at complications in pregnancy, so there's sickle-specific complications, there's pregnancy-specific complications. So obviously sickle complications, that crises may increase. You may like acute chest syndrome. It's pregnancy-specific complications. There's a higher risk of thromboembolism, urinary tract infection, spontaneous abortion, and preeclampsia. And there's also increased incidence of antepartum hospitalizations, postpartum infection, caesarean section, low birth weight, preterm delivery, prematurity, and IUGR, which we'll talk about in more detail throughout the talk. The team at St Thomas's, led by Eugene, published in the British Journal of Haematology in 2014 an obstetric surveillance system that they'd completed between the 1st of February 2010 and 31st of January 2011, looking at outcomes of 109 women in pregnancy with sickle cell disease in the UK. And the incidence of acute pain was approximately 57%. Those that needed blood transfusion was 26%, UTI 12%, critical care admission 23%. And it was more common in hemoglobin SS than hemoglobin SC. There was no real difference in the incidence of acute chest syndrome, hypertension, and venous thromboembolism. Women with hemoglobin SS were more likely to deliver at less than 37 weeks, and babies were more likely to have reduced birth weight. If we look at the data in more detail, I think what's interesting is that a significant proportion, around 40% of the women were obese, which causes its own additional complications in pregnancy. And although the vast majority were hemoglobin SS and SC, there were also other genotypes that were managed. And I think, generally speaking, hemoglobin SS and S beta naught thalassemia are seen as the severe sickle phenotypes. However, we do see significant complications in even some of the milder phenotypes, and it's very hard to predict. And hence why we suggest all women should be offered at least a management in a specialist centre. And with the other sort of phenotypes, we would suggest anyone with sickle cell disease, whatever phenotype, would be managed in a specialist centre. And these were the sickle-related maternal complications. And as you can see, some were statistically significant, others weren't. But the need for transfusion was much higher, as you'd expect, probably in those with hemoglobin SS. They were more likely to get painful crises. Chest syndrome was quite similar, although it didn't reach statistical significance. And those with hemoglobin SS were more likely to be admitted to ITU, but again, that didn't really reach statistical significance. And if we look at the maternal delivery and outcome, a significant proportion of the SS patients, over 50%, were delivered by cesarean section, compared to only 30%, just under 30% of hemoglobin SC. But small numbers, but VTE numbers were quite similar. Far more likely to get UTIs in SS than SC. But pregnancy-induced hypertension was similar, hypertensive disease was similar, preeclampsia was quite similar. But again, none of these really reach statistical significance. And if you looked at the fetal outcomes, including prematurity, those with low birth weight was more common in hemoglobin SS, and preterm delivery was more common in hemoglobin SS. And if you look at this compared to this study compared to various other studies across the world, and this study, this UK retrospective study in 2010, which was actually a collaboration between St Thomas's and Imperial, and I actually collected the data for that for Imperial. So it was published in 2010 in Obstetric Medicine. But you can see that if you look at the rates of postnatal pain, pulmonary complications, hypertensive disease, VT, it's very variable across the world. And the same for sort of fetal outcome and delivery. And for SS, it seemed to have quite a high cesarean section rate compared to across the world. So ideally, a woman, there should be preconception care, and a woman should have genetic screening prior to embarking on pregnancy. And high-risk couples should be counselled prior to pregnancy about reproductive options, such as prenatal diagnosis or even pre-implantation genetic diagnosis. There was a review of the data from St Thomas's in the British Journal of Haematology, where they emphasise that women are not really aware of pre-implantation genetic diagnosis as an option. And they looked at 60 at-risk couples referred over a 5-year period, having over 74 cycles, and they had a live birth rate of 63%, which is much higher than the 17% that has previously been reported. There are non-invasive methods that have for prenatal diagnosis, but they're not currently available on the NHS as yet, akin to the anti-D screening that is now measured by free fetal DNA, which obviously would be a game changer. Obviously, it's important with the preconception care to optimization of health and screening for disease complications. They should be on folic acid, 5 milligrams daily, ensuring they're on the appropriate antibiotic prophylaxis, penicillin V, or erythromycin if pen allergic. Then vitamin D as per national recommendation for pregnant women. And ideally, vaccinations should be updated, including flu and the COVID vaccines. And any potentially teratogenic medication should be discontinued, ideally 3 months before starting, and that would include ACE inhibitors, hydroxycarbamide, and iron chelators. There was a multi-center retrospective study called ESCORT-HU, where they looked actually at hydroxycarbamide that had been used inadvertently in pregnancy when women hadn't realised that they were pregnant, and in 89% the pregnancies occurred whilst on hydroxycarbamide. And in this cohort, there was no impact on maternal, fetal, and newborn morbid mortality, but it was a very small study. It was only I had sort of 27 women within the study. As we know, theoretically, hydroxycarbamide is teratogenic and can cause ossified cranial bones, absence of eye sockets, and hydrocephaly in animals. But I think general consensus is, ideally women should be off hydroxycarbamide for 3 months prior to conceiving. If we look at the age distribution of chronic sickle cell disease complications, they do go up with age. So you not only have increased risk of renal disease, hypertension, pulmonary hypertension. Some may have chronic lung disease. Avascular necrosis may worsen during pregnancy. So it's important to have all sort of the screening tests done, ideally prior to conception or as early antenatally as possible. So if the woman hasn't been seen preconceptually, she should be offered partner testing. The antenatal care should be provided by a multidisciplinary team, including an obstetrician, specialist midwife, haematologist within a specialist centre, extended red cell phenotype and antibody screen. They should be commenced on low dose aspirin, 75 to 150 milligrams daily, depending on their weight, from 12 weeks gestation to 36 weeks gestation, to try and prevent preeclampsia. Thromboprophylaxis from the Royal College of Obstetric Guidance. Sickle cell is deemed sort of an intermediate risk, and we actually within our centre do give thromboprophylaxis from 28 weeks gestation and 6 weeks postpartum. But if the woman has additional risk factors, we would start earlier on in pregnancy, and obviously they would get thromboprophylaxis when admitted. They need regular follow-up. So initially at 12 to 24 weeks, it's 4 weekly. And then as the pregnancy progresses, 24 to 36 weeks would be 2 weekly. And then from 36 weeks onwards, we would try and see them weekly. And we would monitor for preeclampsia and UTI at each visit. And as well as the routine scans, such as the booking scan, the dative scan, the anomaly scan, they would also have serial growth scans with Dopplers every 4 weeks from 24 weeks. The role of transfusion in pregnancy hasn't really been properly teased out yet. So early retrospective studies showed a decrease in maternal and perinatal mortality in transfused patients when compared to historical controls. But there was the high risk of adverse events such as alloimmunization and hemolytic disease of the newborn. In a Cochrane systematic review in 2013, there were 2 trials and 98 women with hemoglobin SS, and it was felt that there was no clear benefit of prophylactic versus selective transfusion. Data and quality of evidence was insufficient to advocate change in existing policies. Another systematic review in Blood in 2015 looked at 7 studies, and they actually concluded that prophylactic transfusion was associated with a reduced maternal mortality, VOCs, pulmonary complications, neonatal mortality, and preterm birth. As I've alluded to earlier, I'm the PI here for the TAPS2 trial that's being run through St Thomas's by Professor Eugene Arteng-Tim and his team. And this is a feasibility study looking at serial prophylactic exchange blood transfusion in pregnant women with sickle cell disease, aiming to improve maternal and infant outcomes. We're looking to recruit up to, I think aim is 40 women to see whether we are able to then proceed to a larger sort of randomized trial. When last meeting I went to, I think we were on 34, and I think we've got till October to get to 40. And hopefully, we will be able to progress to a proper randomized trial, because I think it's a question that definitely needs answering. So the current indications for transfusion would be, the current advice is that prophylactic transfusion, not routinely recommended for sickle cell pregnancy, but should be considered for women who've had previous or current medical, obstetric, or fetal problems related to sickle cell disease, women who've previously been on hydroxycarbamide due to severe disease, we would switch to an exchange. I've got a woman at the moment who's having twins, so she's definitely having red cell exchanges to reduce her chance of any sickle-related complications. And then women who are already on long-term transfusion programs for stroke prevention or remediation for severe sickle complication will just continue. And of course, it may be required during the pregnancy if they develop acute chest syndrome or stroke. Looking at management of acute painful episodes during pregnancy, ideally a woman should already have an agreed pain management protocol. And if admitted, it should be under shared care. The NICE guidelines on management of acute painful episodes should be followed. So I know within our trust, the obstetricians, I think they've used the gestation of 23 weeks, because I think that's when the fetus is viable, to say that basically if they are admitted with a painful crisis up to 20 weeks gestation, they would come to a haematology ward. If between 20 and 23 weeks it's a sickle-related crisis, they should be admitted to a haematology ward. And then any admissions after 23 weeks should be on the obstetric ward. I know in other units it's different. I know in a lot of centres the cutoff is 20 weeks, and I think I believe at St Thomas's it might even be 18 weeks. But so I'd be interested to hear of others' experience of that. NSAIDs, we do use with caution. It's in the first trimester. This is what the BSH guidance says, and avoid after 31 weeks gestation. But I think it is varied practice. I've heard some obstetricians say they would use it up to 28 weeks, twice a day maximum. And I think the issues are the risk of premature closure of patent ductus. However, the FDA in October 2020 recommended avoiding use at 20 weeks or later. because of the risk of severe kidney disease in the fetus and low amniotic fluid. So again, I'd be interested to hear about others' practice. Opioids can be used, and I think it's just being pragmatic, using the lowest dose for the shortest amount of time. And I found this website very useful. I think I think the acronym is BUMPS, but I know the obstetricians use it a lot to find out whether a drug is safe in pregnancy or not. And I think it's really important to remember that not all pain necessarily is going to be sickle. It might be obstetric, and I think that's often sometimes sort of forgotten. You know, there's obviously increased physical and psychological stress, dehydration, worsening anemia, procoagulant state, increased risk of infection. All of those things will trigger a crisis. And then with birth, there's profound physiological response, increased dehydration, hypoxia, anemia, overexertion, and significant metabolic derangement. But then there are obstetric reasons why a woman could have pain, such as like sort of placental abruption. So it's really important to keep an open mind. So pregnant women who have a normally growing baby should be delivered between 30 to 40 weeks. We would not let a woman go beyond term. A systematic review and meta-analysis does confirm there's increased perinatal mortality in later stage of pregnancy, so abruption, stillbirth, preeclampsia, peripartum cardiomyopathy, and VOC are increased and unpredictable. Hence, you know, we would aim to deliver around 37 to 39 weeks. Mode of delivery. Older studies questioned vaginal delivery as optimal, but more recent studies support vaginal delivery and cesarean section due to obstetric reasons. So, you know, they can be offered vaginal delivery. They can be offered vaginal delivery after a previous cesarean section. Obviously, cesarean sections should be done due to obstetric reasons. You know, they're not without their increased risk of infection and VTE, so it shouldn't be routine. But they are women are, of course, more at risk of cesarean sections due to the increased risk of preeclampsia and intrauterine growth retardation. We mustn't forget the women who've got avascular necrosis or may have hip replacements. It can lead to poor hip rotation abduction, and that obviously needs to be factored in when you're planning for delivery. Yep, they should be advised to give birth in hospitals able to manage both the complications of sickle cell disease and high-risk pregnancies. There should be an MDT approach. Blood should be cross-matched, especially if they've got atypical antibodies. The woman should be kept warm and given fluids with adequate fluid balance to avoid fluid overload. Continuous electronic fetal heart monitoring. We offer women an anaesthetic assessment in the third trimester to go through all their sort of analgesic options. We do use opioids, but we avoid pethidine, and of course they are able to have regional anaesthesia for cesarean section. Postpartum, there's an increased risk of crisis post-delivery of 21 to 25%. So obviously it's important to avoid potential precipitants, so keeping them well hydrated, well oxygenated, early mobilization. And also we need to monitor the baby as well, especially if they have had opiates. The mother has had opiates during the pregnancy for drowsiness. And we would give all sickle women low molecular heparin thromboprophylaxis for 6 weeks after delivery. And then we talk about contraceptive advice, and this is from the Faculty of Sexual and Reproductive Health, where they give various categories. Where category 1 is where there is no restriction for the use of the method, and we would generally recommend either a levonorgestrel intrauterine system or a progesterone only pill or a depot progesterone. The combined oral contraceptive pill comes under the category 2. as well as does the copper coil. And yeah, there is an increased risk of thrombosis, but it's felt that if other options aren't suitable, it can be used selectively, but we have to mitigate against other potential risk factors for thrombosis. So I wanted to just end the talk to just to go through a case that we had, which I think highlights very well the complexity of sickle and in pregnancy and the various complications, and the importance of multidisciplinary approach, and that even with that you can have a successful outcome. So this lady, she's about 40 years old, and she was referred to us from one of our local centres, and we just had a referral saying, she's known sickle cell disease, had a couple of crises in the past, she's had a previous PE, and she's pregnant, and that was the letter. And so we saw her in clinic and did all the screening tests. We nearly had a heart attack when we got her echo back, because it showed that she had a pulmonary artery pressure of about 63 millimeters of mercury. It was very high, and then we rang her and said, well, based on this, we need to do some further tests, and we think you probably should be on a transfusion program, because that's what we have as haematologists. Let us do an exchange transfusion program to kind of get your sickle level down, and we want you to be seen by the pulmonary hypertension team. And she said, oh no, I've seen them before, and oh no, I can't have a transfusion. I remember I had a transfusion at my last hospital, and I just got very sick afterwards, and I really don't want to have a transfusion. I thought, right, so I need to get more. I had to get more information from her local hospital, and it transpired that she had the echo findings had been long-standing. She had been seen by the pulmonary hypertension team at Hammersmith, and they said there was nothing that they needed to do. But far more importantly, which hadn't been in the referral letter, I got the details of her previous transfusions, and it turned out that she probably had an episode of a hyperhemolysis or delayed hemolytic transfusion action, but it was quite difficult to work out. So we thought, right, well, probably best not to transfuse her then. And she came in with a lower respiratory tract infection and a sickle cell crisis. And it looked like she may sort of develop a chest crisis. And so the decision was made to give her a 2-unit top-up. And it was covered with IVIG and methylprednisolone, because we were not clear whether the previous transfusion reactions she'd had were a delayed hemolytic transfusion reaction or hyperhemolysis. Despite that, a few days later, she came back in, and her previous hemoglobin had been around 70 something, and it had dropped to 46, and all the features were compatible with hyperhemolysis. And so we gave her eculizumab, 1 dose, which is a monoclonal antibody C5, which is now recommended through NHS England, and we have to have a HCC MDT approval for it, which we received, and she had 1 dose to good effect. So she's previously had PEs in the past, as said, and then during her pregnancy, her proteinuria worsened, and actually she'd become nephrotic, but she'd had a normal renal ultrasound. She'd also had some mental health issues, and she had depression, and she'd been under the Improved Access Psychological Therapies team. And as I alluded to, we'd given her eculizumab during the pregnancy, but she wasn't vaccinated against meningococcus. She just found it all a bit overwhelming and didn't want vaccination at that point. She wanted to think about it after the baby was born. So the plan was for her to have an induction of labour at 37 weeks, to give her concentrated syntocinon, early epidural, active management of third stage, and then if she was bleeding, there were various sort of local measures could be used, but avoiding ergometrin. I remember we had a high-risk MDT to discuss her delivery plan. I had anaesthetist, all the high-risk obstetricians, midwives, myself. I think it went on for about an hour and a half, sort of planning for this lady's delivery. Because she's high risk of thrombosis and due to a previous history of PE, recent hemolysis, nephrotic syndrome, we were giving her intermediate dose low molecular weight heparin, so high dose sort of prophylaxis at 60 milligrams daily. And so there was the advice around timings, around if she were to have an epidural, and then when to restart and at what dose after delivery. And being also mindful that this was her first labour, so if there was slow progress, we may need to consider giving her sort of further doses of sort of prophylactic low molecular heparin to avoid her missing 24 hours of anticoagulation. There's also concern around bleeding. The target hemoglobin was around 60 to 70, but of course, as haematologists, we didn't want her to be transfused at all, unless absolutely necessary, and so there was a very clear plan for that. And if she did need transfusion, then we would cover with IVIG and methylprednisolone. But we did talk about whether we should give her rituximab prenatally, just in case she did need a transfusion, and that's also been used as a second line as a preventive measure for hyperhemolysis. But it was felt that, and although rituximab has been used in pregnancy, it was felt that because it was all hypothetical, she may not need a transfusion, and then the fact and the risks of giving it so close to delivery and B cell depletion in the neonate, it was just felt that that would be too risky, and people were not in favour of that. And then obviously she could have had eculizumab again if she did develop hyperhemolysis. Very strict fluid balance because of her nephrotic syndrome. The renal team didn't want to do a renal biopsy, so they said they'd follow her up after she delivered, and the feeling was that it would probably normalise after delivery. She needed a cord blood for a DAT, full blood count and bilirubin, as she'd had a pan-reacting autoantibodies. We'd offered her the opportunity to have a venous sample to be taken from the baby to check the hemoglobin electrophoresis, because her partner status was unknown. She needed to be monitored on HDU, have intensive spirometry, care for fluid balance, and offer her the maternal vaccinations for meningitis after delivery. There's obviously increased risk of infection, so having a low threshold for treating that and treating any early signs of meningitis, looking for early signs of meningitis. And she was due to come in for induction of labour, and I think she didn't come in at the time she was supposed to come in. And my colleague Jasmine rang her, and she said, "Oh, I'm finding it difficult to get a lift. Can I not just come in tomorrow?" And Jasmine said, "No, you've got to come in today." And thank God she did, because that was her CTG when she came in. And they basically just had to whisk her into theatre, do emergency caesarean section due to preeclampsia distress. And she had said that she felt the fetus hiccuping in utero the day before. That was the word she used. Her starting hemoglobin was good. It was 71 grams per litre. She lost around 300 mils of blood. There were concerns about the baby's neurology after delivery. There was poor tone, had high lactate, and she was sleepy. And they felt she had a grade 1 hypoxic ischemic encephalopathy. So they covered her for infection and they cooled her to prevent insult. Hypoglycemia was corrected. She had normal neurology on discharge. Her MRI header was normal. She was confirmed to have sickle trait. And we saw her in clinic 6 weeks postpartum, and mum and baby were doing well. And I've been seeing mum in clinic or having telephone consultations with her in clinic because she doesn't seem to manage, she hasn't been able to get to clinic. And baby's achieving milestones, and mum's doing really well with a lot of family support. And obviously, you know, we've got the patient at the centre, but it was a real MDT approach to looking after this woman and helping her achieve a successful outcome in her pregnancy. Got the obstetric team and the high risk MDT, the anaesthetic team, us, the haematologist, community team, safeguarding team, psychologist support, the various medical teams, pulmonary hypertension, cardiology, renal, and the neonatal team. Yeah, thankfully, she had a successful outcome of her pregnancy and is doing really well. If people want to look at any references, then if there's a QR code here and people can scan it, and a whole list of references there that I've used for this presentation. Thank you for listening.
Thank you very much, Mamta, for a very comprehensive and informative talk. I think we have got some, I think we've got some time for some questions. If I can just start by asking a question, Mamta, particularly in light of that, that case that you just presented, obviously quite challenging and concerning case, both for the mother and the fetus. Are there any women who you would actively discourage from having a further pregnancy or having a pregnancy in the first place? And how would you go about doing that based on their maternal and fetal risk?
I think if a woman had severe pulmonary hypertension, then, you know, you would definitely suggest that maybe having a pregnancy is not in her best interest and be associated with a high morbidity and mortality. And what we would do is we would do pre-pregnancy counselling.
Yeah, thanks, Mamta. Any other questions? There's a question from Sarah Stewart-Smith in the chat. So you've got your hand up as well. I don't know if that's the same question you're going to ask.
Yeah, it's just because you were talking about stopping hydroxycarbamide for 3 months, and I know that's always received wisdom, but I've never quite understood why, because I can understand it for men because it takes that long to make a sperm from beginning to end, but given that women are all born with their eggs, why does it need to be 3 months? Just wondered if anyone had any thoughts.
A very good question. I think it's just arbitrary, isn't it? And actually, yeah, no,
and actually 3 months is a problem, because then they've got long enough for it all to wear off and get sick.
No,
sometimes before you've started an exchange program, which is a bit frustrating.
No, I know, but we usually, as soon as we stop the hydroxycarbamide, we put them on the exchange. We wouldn't wait for them to get into trouble. If someone was on hydroxycarbamide, we tend to just switch them.
Yeah, I was thinking more in a different case. So we had a patient, well, we've got a couple lately that are doing egg freezing. Seems to be the flavour of the month. So they're not going to get pregnant straight away. They just want an interval to collect eggs. And I wondered what people think about hydroxycarbamide in that setting. So part of me thinks you could just stop it for a couple of weeks so it's out of the system and you've got your egg and you've frozen it. Does anyone have any thoughts?
Well, from the HU escort study, you know, they all did well. They were all okay.
Yeah.
while they were on it. And actually, we did discuss a case. I don't remember if Asad you remember and Stephen you remember. It was a HCC MDT. It was a case from Scotland, and it was very, very complex. And, you know, as someone who was like virtually impossible to transfuse, but had a really severe sickle phenotype. And it was actually, you might end up having to give them hydroxycarbamide for some of the pregnancy.
So we've had a couple in the last year where we've deliberately given hydroxycarbamide
Yeah.
after an early anomaly scan. So we sort of brought it forward
Yeah.
a bit when
No,
we're really
exactly.
unraveling with hyperhemolysis and
Yeah.
really severely
Yeah.
unwell, and then do that anomaly scan so that we can all
Yeah.
feel, yep, that's all fine.
Yeah.
It wasn't the hydroxy, and
Yeah.
then start it.
Yeah, no, exactly. Is that Beverly? You've got your hand up. Is that your case?
Yes, it was. It was just to let you know that after the MDT, back to that lady. Sorry, it was just to let you know that after that MDT, I went back to the lady and spoke to her about it, but she's quite adamant that she doesn't want to be on hydroxycarbamide, so she's come off it. She's actually been quite well off it, but her hemoglobin's drifted down to sort of high 60s, 70s, and she's not fallen pregnant yet. But I was interested to hear that you had actually used eculizumab in
Yeah, no,
pregnancy.
we did. Yeah.
So I've got sort of pre-approval of that in case. Yeah, we'll just have to see how it goes. Thank you though for that.
Thank you. Any further questions for Mamta?
It would be interesting
Not-
just to have a straw poll of what age people get their patients admitted under obstetrics, just to have an
Yeah.
idea. If people can just put it in the chat or something, because it seems to
What do
vary
you
much more
do?
widely. So at King's, it's more than 16 weeks, which is
Oh, really?
really early. Whereas when I was at Queen Elizabeth, it was 24 because then they said it's viable pregnancy.
Yeah,
I don't
so
know. It just
here
seems
it's
to vary
23
everywhere.
yeah, because that's where they got the 23 weeks, because it said it's viable fetus from there.
Yeah. If anyone could put their numbers in the chat, it would just be interesting to know what the range is, what sort of numbers come up a lot.
But what we have, the problem that we have, I don't know if other units have the same, is that it's really difficult for the midwives, you know, because they're not familiar with PCAs. So actually, the management of a painful crisis is quite difficult on an obstetric ward if you're using a PCA. So we have to rely on our nurses to come across and manage the PCA. I don't know if you have the same situation.
We don't use PCAs as much, and I don't feel, I think we have had, yeah, we've definitely had them on maternity, and it's not been a big problem. Maybe they're just got used to it. I don't think that's an issue for us.
Yeah, we have quite a low prevalence of admissions with sickle cell at the RVI in Newcastle, but we do actually see women from other complex obstetric obs med clinic, like women with pre-existing medical conditions to do with cardiac disease, lung disease, and they are seen actually very early on within the obstetric department through the maternity assessment unit, maybe even as early as 14, 15 weeks. So it's quite a stark contrast to some units where they're like 20-week cut off, 16-week cut off. But I would imagine with women who are experiencing sickle cell crisis or suspicion of that, we would be getting a prompt review and then a decision based on where that care would be best given, whether it would be on the antenatal ward or whether it would be indeed in one of the haematology wards. So it would probably be a case by case basis, but we would probably bring the women in via the maternity assessment unit quite early on here at the RVI, maybe even, as I say, 14 weeks, 15 weeks, and then we would get them consultant review early so they can take the decision on where the patient would be best managed.
So another question for me for Mamta. Could you just give us some tips and advice how you would manage a woman with severe iron overload in pregnancy, given that all the iron chelators are contraindicated, and they may also be contraindicated during the period of breastfeeding as well, which may also be a prolonged period.
So thankfully, it's not really tends to be an issue with the sickle cell patients. It's more my experiences of one, which is a lady that we had with e thalassemia actually, who had significant iron overload with a liver iron concentration of more than 43 milligrams per gram of dry weight in the liver, but amazingly no cardiac iron overload. So you basically no iron chelation, but then from 20 weeks you sort of can give Desferal at a low dose. I think it's 20 mg per kilogram through the pregnancy, and then once they've delivered, you can increase the dose of the Desferal, and then when the woman stopped breastfeeding, then you can restart the oral iron chelators.
Thanks.
Can I ask about, are there any obstetricians there about NSAID use in pregnancy? Because I think it's clearly quite variable. Or any midwives who know what their colleagues?
From a perspective of a midwife's perspective, working in high risk antenatal services, we don't tend to use NSAIDs routinely. I have known them be used very rarely, but again, just on a case by case basis. So they're usually recommended that we don't give them. Most of our patients wouldn't have them. I've known them use them a couple of times, usually from
I think we've lost Kerry. You've frozen, unfortunately.
Hello.
Yeah, just got you back.
Yes. Obstetric unit. Very occasionally they're used, but usually recommended against. Would usually go to first line opiate-based analgesia.
Kerry, I'm afraid we're not hearing you very clearly. So if you've got any other important comments, if you could put them in the chat for us, that'd be very helpful.
No problem.
Thank you very much. We've got time for one last question, I think. No, so if there are no further questions, then I'd just like to thank Mamta again for giving a very informative talk. And thank you for all the people attending. We had a very good attendance today, over 60 people. Thank you very much, everyone.
Thanks.